Everyone. Welcome to the Swetland Seminar. My name is Deena Webb. I'm a project manager here at the Swetland Center for Environmental Health at Case Western Reserve University. If you're not familiar with the Swetland Center, in the late 1950s, David Swetland and Marianne Swetland felt not enough was understood about the unintended health consequences of chemical, agricultural, and industrial products in our environment. So David Swetland focused the Marianne Swetland Professorship of Environmental Health Sciences on preventative medicine and the threats of man-made environmental hazards so that all graduating doctors would have an interest in and understanding of the impact of the environment on human health. So for over 30 years, the Marianne Swetland Center for Environmental Health has cultivated partnerships to develop and expand solutions that enhance environmental health for everyone. Our work encompasses various exposures influencing health outcomes throughout life, such as asthma, chronic diseases, mental health, and infant vitality. We're recognized for a collaborative and adaptive approach that transcends boundaries to foster healthy environments where people thrive. So we're glad that you all could join us today. Please feel free to share your name and the organization you represent in the chat box. We always like to hear where people are joining us from and how they heard about our seminar series. So our mission at the Swetland Center is to accelerate pathways to vibrant and healthy environments through collaborative research, immersive training, and authentic community engagement. We have a three-pronged approach focused on research, training and education, and community engagement. And our goal is to build capacity for the next generation of scientists to work alongside community partners to promote healthy environments for people to thrive. Okay, so our next Swetland seminar is on Wednesday, March 18th. So it'll be at a different day and time from our usual schedule. It's from 12 to 1 p.m. on Zoom on that Wednesday. And we'll make sure to put all these links in the chat and you'll get a copy of the slides later today. You can also subscribe to our newsletter or visit our website, which is always updated with our calendar of events. So the March Swetland Seminar is gaining consensus on metrics of nutrition equity for urban food systems. Dr. Darcy Friedman, Dr. Usua Yamoa from the Swetland Center will be presenting. Okay. And I will turn it over to the Swetland Center's director, Dr. Darcy Friedman, to introduce today's speakers.
Good morning, everybody. It is a pleasure to be here this morning and also really nice to see some friends from all over Ohio and beyond in our seminar today. So I'd like to introduce our two speakers, Dr. Deena Chisolm and Dr. Kierra Barnett. I have known Deena now for about a decade and am very excited to have the opportunity to hear her present today. Deena is the nationwide Foundation Endowed Chair of Health Equity Research, Director of the Center for Child Health Equity and Outcomes Research, and Vice President for the Health Services Research in the Abigail Wexner Research Institute at Nationwide Children's Hospital. She's also a professor of pediatrics and public health at The Ohio State University. Her research focuses on improving health and health care for children and families with over 120 peer-reviewed publications on pediatric health services, outcomes, and disparities. Her current projects explore how health literacy, health policy, and social factors influence the health of at-risk adolescents transitioning to adulthood. Her research is funded by several agencies, including the National Institute on Minority Health and Health Disparities and the National Institute on Drug Abuse. Dr. Chisolm is the immediate past chair of the Ohio Commission on Minority Health and serves as a board chairman for the Health Policy Institute for Ohio. She earned her BS in Biological Science Education from Miami University, MS in Preventive Medicine, and doctorate in Public Health from The Ohio State University. Dr. Kierra Barnett is a senior research scientist at the Center for Child Health Equity and Outcomes Research at Nationwide Children's Hospital. As a mixed methods researcher, she uses both qualitative and quantitative methodologies to improve health inequities experienced by historically marginalized populations. Dr. Barnett's scholarship is translational, She has collaborated with government, community, and academic partners on health equity research with an eye toward informing and developing future intervention studies, institutional practices, and public policies. Her work specifically aims to understand the lived experiences of those most deeply impacted by health disparities and include their voices in the solutions we generate. Dr. Barnett earned her PhD in public health from The Ohio State University, where she also completed her Master of Public Health. Additionally, she holds a BS in Community Health from the University of Illinois. So without further ado, I'll turn it over to our amazing speakers for today.
Good morning, everyone. I am going to try to be as chipper as possible. I am not famous for early mornings, and 9 o'clock counts as early morning for me, but I'm going to do my very best. So first of all, thank you to Darcy for the invitation for us to speak. As she said, we've had the opportunity to know each other and collaborate over projects over the last several years, and excited to be collaborating with her on some of the projects we're going to talk about today. And what we are really going to focus on today is a specific study that we're working on that's looking at how we can think differently about how we invest in health, and particularly how we invest in health in a way that is conscious of why needs exist in the way they exist in the communities in which they exist. And so this is a study called Targeted Investment and Meaningful Health, or the TIME study. And we're going to talk about that within the framework of a number of research projects going on in our center that are focused on housing and health. So next slide. So as was mentioned in the introduction, we live in the Center for Child Health Equity and Outcomes Research, which has a mission that aligns with the Swetland Center mission. So our mission is to advance child health and well-being through research in and across clinical care, health services, health policy, and community initiatives. So really our goal is doing work inside each of those areas, but much more importantly, how we are linking the way clinical care interacts with health policy, the way health services research considers community initiatives. So really focusing across this space. And our vision is to lead the nation in groundbreaking research that produces reduced disparities, vibrant communities, flourishing families, and best outcomes for all children. And when we think about children, we think about children not as independent entities in space, but existing within families that exist within homes, that exist within neighborhoods, that exist within geographies, which allows us to have a very broad approach to doing child health research. We are a center of 14 faculty, about 75 staff, who are a mix of MDs and PhDs who are doing studies across a number of clinical areas and a number of policy areas. And we really bring to bear on that work clinician expertise. So about half of our faculty are clinicians, but then also large data analysis, epidemiology, qualitative methods, and community engagement. We also have a large focus on mentorship and training. So I just want to share a little bit about who we are and where we come from. Next slide. So as I mentioned, we think about children within families, within homes, within neighborhoods, within geographies. And one of our core components of our health focus is understanding specifically how health and how housing and how neighborhoods affect health for children and families. So we have a large body of research in this area, and there's a citation slide at the end of this presentation. And so when the presentation is shared with you, you'll be able to see what the citations that are being referenced are for this work. But what we've learned from our previous studies really informed what we're doing now. So just want to rise up a few of the things we've learned over the years of doing this work. First of all, that having a home can improve the health and the success of health interventions for mothers and youth. Now, that probably does not sound like a shocking statement, but even if something isn't a shocking statement, we have to prove it, because if we don't prove it, somebody's going to say, how do you know? So we've done research, particularly in unhoused adolescents and in housing unstable pregnant women to understand how does addressing their housing situation improve our ability to address their other issues, whether that's healthy pregnancy care or whether that's substance use and treatment. And what we've seen is that pregnancy interventions, um, interventions designed to reduce infant mortality and maternal morbidity do better when we use a housing first approach where first we make sure they have a stable place to live. And we've also seen that with youth who are unhoused, who are also experiencing substance use issues, we have a better chance of addressing their substance use issues successfully if we first address their housing situation. Uh, Again, like I said, that's not a huge surprise, but one of the pushbacks we get on this work sometimes is like, well, why wouldn't I then just get pregnant if you're going to help me get a place to live? Or why wouldn't I just go on drugs if you're going to help me get a place to live? So part of what we have to do is show that those things are not independent, and that nobody's making that choice when we do this kind of a project. So having a place to live makes a difference in our ability to address people's health. Secondly, that the quality of that place to live is associated with health and healthcare use for children and families. So we did two large studies using the Survey of Income and Public Program National Survey that looked at housing quality, and that meant cracks in the walls, that meant leaky plumbing, that meant other visible damage, and to see whether having multiple things wrong with your house were associated with the level of health. And what we saw for both children and adults was that the more housing quality issues, the lower your overall health. Now, we're not saying that one caused the other. They could be related, associated in ways that aren't causal. But knowing that quality of housing is associated with health allows us to think about how could addressing quality impact health, or how could knowing that people have quality issues help us to identify health issues. We saw the same thing with healthcare use. So emergency department use, hospitalization was higher in people who lived in houses with more quality problems. And then the third finding was that neighborhood level improvements are associated with improvement in health and safety for children. So this is research that's done as part of our Healthy Neighborhoods, Healthy Families program, which I'm going to talk about, but really looked over a decade of community investment that's focused on improving housing and improving education and improving neighborhood safety. What did that do for the health of the children and families in those communities? And what we saw was, I won't say a significant change, but I will say a signal that supported the probability of a change in chronic illness and emergency department use in children as we improved the neighborhood around them. We also saw some changes in the crime structures in those same neighborhoods. So again, working and improving a neighborhood can be part of improving health. So having houses, having those quality houses be in quality neighborhoods all come together as part of a way that we can think about addressing health beyond the doors of a really big children's hospital where we are situated. So next slide. That combination of findings led us to the time study, which, as I mentioned, is about targeted investment and meaningful engagement. It's an R01 funded by the National Institutes for Child Health and Human Development, and it is centered in a community called Linden, which is in Northeast Columbus. Next slide. So, as anybody who's done public health in Ohio over the past decade knows, one of our most enduring health disparities is infant mortality. We have unacceptable levels of infant mortality overall in the state of Ohio, and additionally, unacceptable disparities across racial ethnic populations in those infant mortality rates. So simple stats between 2011 and 21, we saw that white infant mortality rate improved by 37%. This was due to a whole lot of really, really hard work by the public health communities and in our large cities that took the brunt of this work. We also saw improvement in the Black infant mortality, but at a much slower rate. And when you have one group getting better faster than another group, you actually have expansion of the disparity. So you have a situation where everybody's getting better, yay, but we're seeing bigger differences between populations. That is not okay. So with that in mind, you look at this pace, it's going to take, at least 49 years to reach health equity. And that would only be if one of the groups stopped getting better. So, which is not our goal. So this is why we're doing work in infant mortality that aligns with our housing and neighborhood work. So next slide. So I mentioned racial disparities in maternal and infant health are longstanding nationally and locally in Central Ohio, that we know that these disparities are associated with a number of social determinants of health, including housing, and that these social determinants of health, including housing, are often rooted in place-based discriminatory policies. So that were the thoughts that brought us to this study. And then the place where we know all of these things are existing in one place is Linden. So next slide. So Linden, I mentioned, is a traditionally long-term disinvested community in Northeast Ohio, about 18,000 residents, predominantly Black, large proportion poor, challenges compared to the county as a whole in terms of educational attainment, unemployment, housing vacancy, crime, and one of the highest community level infant mortality rates in the county, and also high rates of low birth weight. So we said, if we can make a difference, can we make a difference in a place where there is a huge opportunity for that? And that's how we picked Linden. We also picked Linden, next slide, because of its strength as a community. So I just had a slide up that had all sorts of negative stuff about Linden. I don't want to stop at negative stuff about Linden. Linden is a vibrant community. It has a fresh market. It has community organizations that have been standing for a century. It has a lot of neighborhood pride. You see people, we have murals about the community celebrating it. People have sweatshirts. We are Linden. People who are actually working together to rebuild their community. And we became part of a larger scale initiative focused on that sort of rebuilding. So next slide. So Linden became part of Nationwide Children's Hospital's Healthy Neighborhoods, Healthy Families initiative, which started on the south side of Columbus, which is really right outside the front door of the hospital, where we had been doing neighborhood development for a decade. But we said, we need to go further. We need to go somewhere else. We need to expand our footprint. So we partnered with the Linden community and with a commitment to contribute $3 million to a citywide $13 million approach to community reinvestment. That is, you see, stops in 2022. It did not stop in 22. There's been continuing investment since that point. And those targeted reinvestments have been intended really to improve the housing quality, which we said was associated with health, and affordability, which is associated with access. And then also a lot of other social factors, health and employment and health care, and really the neighborhood's relationship with others in the space. So this was a perfect storm of a need, a known predictor of that need, a community that was ready to engage, a partner organization that was ready to invest. And we as researchers were able to come in and say, how does all this work together? And how do we do this type of work in a way that's informed by the community and its history? And so that is the ground that the time study is built in. And so I'll turn it over to Kierra to tell you more about what the study is actually doing.
Awesome. Thank you all for coming and joining us this morning. So, as Dr. Chisholm mentioned, our time study is really guided by this question of, how important is it that we include this history of the community in order to rectify some of the harm done by discriminatory policies over time. So the overall objectives of the time study is to describe the discriminatory policies that have influenced infant mortality rates and other maternal and child health experiences, outcomes that have been experienced for generations of Black women in the community. And then we want to demonstrate how community reinvestment can be designed to target and rectify both the historic and contemporary discriminatory policies that have shaped the neighborhood. So our team for this time study is very interdisciplinary. So we have our team here at Nationwide Children's, led by Dr. Chisholm. We work with folks in the College of Public Health at OSU, as well as the School of Agriculture, particularly in the City and Regional Planning Department. And then our colleagues at the Kerwin Institute for the Study of Race and Ethnicity at OSU. And then for the last year, we've had the pleasure of having Dr. Freeman and her team at CASE join our team and help us with the group model building, which I'll talk about in a little bit. So this study overall has several different aims. And our first aim, the research question is focused on how have community level policies, and really specific to housing, impacted the birth outcomes and experiences among Black women over time. And so to accomplish this or answer this research question, we've kind of engaged in a couple of different methods. The first is that we've done a policy analysis and a opportunity mapping. We've also interviewed Black birthing people, and then we're engaged in a group model building. So I'm going to take a minute and talk about each of these methods and kind of what we've learned thus far in this project. So back in February of 2024, Health Affairs published a special issue on the impact of housing on health. And we were very privileged to be a part of that special issue and kind of share some of our initial findings from this work. In that we tell this 100-year story of Linden and laying out the policies that over the last 100 years has created Linden to be what it is today. And you might think like, well, why do we have to talk about policies in the 1920s when we're looking at outcomes in, the 2020s? But it's really important to understand how a community came to be. I think in the absence of understanding that history and taking that into consideration, we can fall into this trap where we start to blame the people who live in those communities for their current conditions, right? So Linden is this way because the community doesn't care, or the community, are bad actors in maintaining spaces. When the reality is there have been these policies over time that's kind of created these conditions in which people are living in the community. And so you'll have these slides, so you'll have the link to this publication. And a part of this publication is they also created this interactive tool that you can kind of walk through the policies that's laid out in that publication. In addition to the publication and Health Affairs, specific to this policy analysis that we did, we're also in the process of creating what's called a story map. It's scrolling really fast on the screen, but this is just a kind of a demo of what this is going to look like. So we recognize that not everyone's going to read academic publications on the topics that we produce, but we recognize that this information is important and it can be used for advocacy by community members and also policymakers. And so we have created what's called a story map, which kind of walks people through this story of what has happened to Linden over time through the different policies. And it's a tool that we're going to make available online for, again, community members and decision makers to really be able to tell that story of Linden and use it for advocacy. And in that, we include also some narratives that we've heard in the interviews. And at the end of it, we also have an asset mapping where we really highlight some of the resources that we see in the community as well. So again, highlighting the history of what happened, but also sharing that the positives about the community, because we always want to make sure that we're also uplifting that in what we do. So I'm going to take a minute and talk about some of the different policies that's included in that policy inventory that we did. That's a part of that publication and in that story map. So I'm going to start us off in the 1930s. Many folks have heard of redlining. Oftentimes when we talk about discriminatory policies related to housing, redlining is the first one that we all discuss. And so if you're not familiar, the kind of short story of redlining is that this was a national practice or policy enacted by the federal government to assess neighborhoods for risk for mortgages that were backed by the federal government. Again, this practice happened in the 1930s through the 50s. And what we saw is that communities were being graded for their risk, and they would receive a grade of A through D. Again, this is the 1930s and 50s. Racism was alive and well and out in the open at that time. And so a lot of these neighborhoods were being assessed based on the racial makeup of the community, and that's how we were determining risk. So the image on the right is the Linden community, and we can see here that the community received either a C or D graded in the area. Important to note that C grading was also given to a lot of white immigrant communities during this time. As you can see, based on the community demographics on this slide, at this time, Linden was predominantly white. It was 96% white. So it's received mostly a C grading, but we do see those D graded neighborhoods. And those are in red. And those are the areas where we saw our Black population during this time. So kind of the impact that this policy had on this community is a loss of opportunity to generate wealth. We know in this country, our main vehicle for wealth generation is through land and property ownership and the way we can pass that down through generations. And so this blocked a generation of folks from being able to obtain wealth. And it also created this disinvestment in community resources. So if folks aren't able, not only were folks not able to buy homes because of this policy, but it also hindered businesses from getting loans as well to come into the community. So it had an impact in that way. Kind of a less known or talked about policy that also impacted a lot of communities nationally is block busting, and also the highway constructions that happened in the 1950s and the 60s. So block busting was a practice in which realtors essentially scare white homeowners into selling their homes for really low prices. So telling white homeowners that, you know, minorities are coming into your community, your property value is going to drop, and so you should sell to me right now at this rate so that you can get out before things get too bad. Those same realtors would then take that property that they got at a discounted price and resell it to individuals of color at a much higher price than what the property might have been worth at the time, right? So it's a way for the realtors to kind of make money at the expense of minority communities. And so we saw this happening in the Linden community as well, and that helped change, or that began to change the racial dynamics of the neighborhood. And at the same time, we had the highway constructions that were happening. So as this block busting is happening, and we see the increase in white populations moving to the suburbs of our cities, we decided that we needed to find a way to make the commute from the suburbs to downtown, where most folks work, a little bit easier. And so we had to build highways. And oftentimes we were building those highways through our Black and Brown communities. So it really kind of aligned, and I'll show on the next slide how it aligns with those communities that were redlined. So a lot of these policies kind of worked in tandem with one another in creating the conditions that we see. So this image is actually an image of the Linden neighborhood in while 71 was being built through the city. So as you can see kind of here in the center of the photo, you can see where homes and neighborhoods were kind of destroyed. You see like these empty plots that used to be homes that were destroyed in order to make 71. This created an actual physical barrier dividing Linden from the more affluent neighborhoods and businesses that were just to the west of the Linden neighborhood. And at this time, we had about 32,000 residents in Linden, and we started to see, again, that shift in population, where in decades before, it was 96% white, and now we see it's at 83. So we start to see this decrease. And so this is just a slide showing, this is a red line map of Columbus as a whole. Again, Linden is right in this area on this map, but this is just showing where the highways flow through the city in relation to this red line and map. And just here wanted to emphasize that, again, we see our highways are being built through our red line communities. So our Black communities were the ones that were harmed by the creation of these highways. And this is not a unique experience in Columbus. We saw this happening nationally, where we went around our A and B graded neighborhoods, so our predominantly white neighborhoods. We made sure that the highways didn't disturb those neighborhoods in the ways that it did our Black and Brown neighborhoods. And so now I'm going to flash forward to the 2000s. In that paper, we talk about the desegregation of schools that happened in the 1970s and the way in which Black students at Lyndon McKinley High School really advocated for their needs in the school systems. And we talk about the war on crime or the war on drugs and mass incarceration and the way that also impacted Lyndon. But I'm going to skip over that for today's presentation and then talk about the subprime lending crisis that happened in the early 2000s. So we know in Linden in 2006, more than 50% of all home loans were subprime loans, right? So that meant that these folks were more likely to experience foreclosures. And we see that in Linden, they had the highest rate of foreclosures in our city during this time. In terms of the community dynamics during this time, again, now where in the 50s and 60s, it was still predominantly white. At this time, we're seeing almost 70% of the Linden population are Black. We're starting to see high rates of vacancies, vacant homes within the neighborhood. And then we're also seeing a higher rate of renters within the neighborhood. Historically, Linden had been a neighborhood that had high home ownership. And at this time, we're starting to see this switch where majority of the residents in Linden, or close majority to the residents of Linden, are renters. And then in the early 2000s, here's where we start to have data at the neighborhood level that we were able to get from the city around what infant mortality looked like. And so we start to see that the Black infant mortality in Linden is much higher than the rest of the city or the rest of the county during this time as well. So we start to see that. And then since the 2010s to now, we have seen some revitalization in Linden. The map on the left is of Celebrate One. So Celebrate One is our infant mortality initiative here in Franklin County. And this is a map of kind of their target communities where they are aiming to really improve infant mortality rates, and they're doing a lot of programming. And so that circle area is the Linden neighborhood. So it is one of the target areas that's receiving a lot of investment in terms of programming in order to reduce infant mortality. The city has also come up with the One Linden plan, and they just came out last year with an updated plan that really talks about like how we can revitalize the Linden community. And then we have initiatives and grants that the city has won, like Smart Columbus, that's aimed at improving transportation in the community. And Linden is one of the areas in which they're trying to improve transportation for residents. And so we have all of these really great initiatives and things like that are happening. But again, we have to think about the history that kind of got us to this point as we think about initiatives to improve disparities. There's a lot of conversations happening among residents as all this investment is happening in Linden around who is this investment for, right? So this kind of concern about gentrification, and that's not gentrification on our behalf as Nationwide Children's, but also just in the larger grand scheme of the city doing a lot of different initiatives in the community. And so if we don't think about the history and the way in which Black community members have been like shuffled back and forth throughout the city, and again, that's not a unique experience to Columbus or to Linden, but if we don't consider that history as we plan for future intervention, we might find ourselves back in the same, in the same place. So as I mentioned, so that's the policy inventory that we're doing as a part of this project, or that we completed. And we're also doing interviews with Black women who live in Linden. So this is just some demographics of the women that we've interviewed so far. So far, we've had the privilege of interviewing 61 women. These interviews they're one-on-one interviews that last about, I would say on average, probably like an hour and 15 minutes per interview. And we were really interested, as we told this history with policy, telling this history with people and their lived experience. So we wanted to interview people who have lived in Linden and been pregnant during the time where they lived in Linden over an extended period of time. And so the age range of the folks that we've interviewed range from 19 to 75 with a mean age of 40. And if we look at the year that they experienced their first pregnancy, because some of these women had multiple pregnancies, they range from 1964 all the way to 2024. So that person was pregnant while we were interviewing them. When we look at our education level, we see that majority of the population that we've interviewed has at least a high school education, with about a third of the population having some college or more. And then we see that 53% of the women we interviewed experience any sort of pregnancy or birth complication. So that can be preeclampsia, experiencing a miscarriage, gestational diabetes, kind of any sort of complication to their pregnancy. So we see a little bit more than half of our population has experienced that. So we are currently in the thick of coding. So again, as I mentioned, these interviews are like over an hour. So it is a lot of information to code, a lot of information to digest. And even for myself, and I know our colleague Brittany is online as well, who's helping with the coding. It also takes additional time because the stories we hear are heavy, and we as researchers have to take our breaks and engage in self-care in order to carry these stories and again hopefully find solutions for them. So just some high-level preliminary findings from the interviews. The women talked a lot about challenges finding affordable housing within the Linden neighborhood. So some of this, a lot of houses, they talked about having a high cost but poor quality, right? So the slumlords in the neighborhoods are charging, over $1,000 for a unit that might have, plumbing that isn't working properly or pests within in the homes. And so they talk about kind of this, this struggle of like, well, I want to live somewhere nice, but it's even the places that aren't nice are just really unaffordable right now. And then those who are on public assistance has even shared kind of the challenges that come with that. So being on public assistance, if your name gets pulled from the drawing to receive Section 8, but now you have to find a place to live and there's a clock on how long you have before they kind of go to the next person on the wait list for Section 8, and how there's also this challenges with finding affordable units within that. We also, in the interviews, talked about their perception of safety within the neighborhoods. A lot of women shared this sentiment of like keeping to themselves in order to stay safe. So we would ask like, well, what makes you feel safe in the neighborhood if they told us they felt safe? And they would say, well, I kind of keep to myself, right? I don't really hang out in the streets, or I don't talk to a whole bunch of neighbors. So like this idea of like keeping to themselves is their way of staying safe. And then we also talked about like unsupervised teens in the neighborhood as a challenge. And the women were, the word I'm looking for, like they understood that a lot of the unsupervision that was happening is because parents are working, right? So again, thinking about this unaffordability, that parents might be working multiple jobs, and so they just don't have the time or the space to supervise their teens, but in the ways in which sometimes that left teens to their own devices, and maybe they're hanging out with the wrong crowds and getting into trouble within the neighborhood. So that was also a concern that came up in a lot of our interviews as well. And then finally, we talked about a sense of community. So they talked a lot, particularly the long-term residents in Linden, or a lot of these women also grew up in the neighborhood. So they'll talk about kind of the past Linden versus now, and this idea that community members were a lot more engaged with one another during that time in the past than they are present day. So kind of this loss of community connectedness that has happened over time. And we've talked about that some of that loss might be because people are constantly moving, right? So if you aren't able to have a stable house, how can you build relationships with those who live next to you because you're constantly moving? And I remember one interview specifically talked about like not wanting to build those relationships, right? Because she felt like it would make it hurt more if she had to leave her home because it was unaffordable, right? So just thinking about how affordability can play a role, excuse me, into social connectedness. But overall, there was this overall pride within Linden. They talked about Linden having a bad rep, and that people on the outside felt that Linden was this like scary place to live or dangerous place to live, or being treated differently because they were from Linden. But they had a lot of pride in understanding that Linden is a really good neighborhood, and the folks in Linden really do care about it. And I don't have a slide on this, but the other piece of this that I mentioned is the group model building. And so that's the work that we're doing with Dr. Friedman. And that's really aimed at bringing in, so we've had 2 out of 3 of our group model building sessions, and that's really bringing in the community members and having some discussions around what sort of things would improve infant mortality rates and prematurity rates in the Linden neighborhood. And so as a community, they've been able to co-create this model of the things that we might need to change in order to see improved outcomes. And so that work is in progress, and we'll hopefully have more to share with that in the coming months. So our second aim of this project is really to understand how censoring these discriminatory policies within community development plans can influence the approaches that we take to decision making. And so the method for this aim is that we want to take everything that we've learned in that first aim. So it's the policy, it's the interviews, the group model building work, and then share it with our leadership in healthy neighborhoods, healthy families, and then have interviews with them to say, well, was this actually important? Did you find it relevant to what you're doing? Get some information and some feedback on the process, and if they thought that it was a quality process of sharing this information, and the impact that it had on the planning that they do. So again, our research question is understanding this history and this storytelling, is it important to the way in which we plan community development? So that is our second aim, that again, as we're wrapping up, understand our findings in aim 1, we'll move into aim 2. And then our third aim is just looking at how community reinvestment interventions have changed birth outcomes in the Linden community. And so we have data from the Ohio Department of Health on infant mortality rates and birth outcomes from 1990 through, I think, 2023 is the data that we have, but we're going to continue to get data going to present date. And we're looking at a matched control communities in Ohio to identify, do we see significant differences and changes in birth rates over this time where Nationwide and others have been investing in the Linden community. So if you look at a community that might not have had as much investment, but has similar housing structure, similar population, do we see some changes over time? And then we're also implementing a questionnaire currently, and the questionnaire is aimed at understanding neighborhood perceptions among community members as well, to try to see if people start to feel differently about the neighborhood as we've been investing this money into this work. And so aim 2 and aim 3 work is forthcoming right now. And I'm going to turn it back over to you, Deena.
So, just to wrap up, this project is wrapping up its 4th year. We've got about another year and a half worth of work that we hope to do. So we hope to have 1 year funded and 1 year of no cost extension to get through everything. We'll see how that goes. We have been fortunate that we've been able to continue this work even in the current environment. We hope to retain that fortunateness going forward, because we think this is important work, and because we think that it's not something that should be seen as divisive or something that should be seen as threatening to anyone. It's really about understanding where we come from so that we can do a better job of getting to where we want to be. And so this story we're telling about Linden isn't unique. There is a Linden or 2 or 4 in Cleveland. There is a Linden or 2 or 4 in Cincinnati. So what we want to do, and we know none of them are the same. So what we learned is not going to be portable to any of those places, but how we learned it will be portable to those places. And that's what we really want to do, so that we can get to the point where community development is really situated in a way that allows for what has happened on the ground, the nuance of the community, to inform the direction that it goes. But we have to figure out how to do that best. We've got to figure out how we can communicate that to decision makers in a non-threatening way that makes them understand how it can be helpful. Because right now they're like, why does any of that matter? We just need to fix the problem. So thinking about how we can build that discussion in a way that is most impactful to making the most out of large-scale investments that are coming into some of our traditionally underinvested communities. So next slide. Ultimately, our goal is that we develop an approach to engaging health systems in community development in a way that centers health and centers history. in a way that recognizing that those two things cannot be fully disaggregated, but that health systems are part of the solution, may have in the past been part of the problem, but today are part of the solution to developing community development approaches that are rectifying the past and improving the future. So next slide. What have we learned along the way? Dr. Barnett shared some of this. Communities are receptive to doing this work when you acknowledge their expertise. When you walk into their community, not I'm the PhD from OSU Nationwide Children's and I'm going to tell you what you need, but really saying, I need you to tell me what I need to know to do a better job, acknowledging that they're the experts about their space. Recognizing that just because we walk in wearing Nationwide logos or OSU logos, those things have both positive and negative associations with them. People have had positive and negative experiences, and we have to recognize that all of our regalia can sometimes bring positive recognition of expertise, but also can bring up negative emotions that we have to be able to manage. We do a lot of work in rural health here as well, particularly in southeastern Ohio. And what we're learning is that the challenges in rural and challenges in urban have a lot of root causes that are associated with limited economics, but that the reasons for those challenges differ and the ways for addressing them is different. We can't take, one hammer to every thing that needs to be built. This work is interdisciplinary, as Dr. Barnett mentioned the building. We've got architects, we've got epidemiologists, we've got sociologists, we've got biostatisticians who are coming together to do this work because it has to be interdisciplinary. We've got historians involved. And it's resource intensive, doing those hour and 10-minute interviews that Dr. Barnett and Brittany have done takes a lot. And it's not just the hour and 10 minutes, but it's the mental processing and emotional processing that you have to go through as you're doing that and after you've done that to maintain your own health. We're learning that there is no quick solution. The work we're doing on model building, group model building is showing there's a lot of things that we think might make a difference, but most of them won't make a difference tomorrow or next week or next year, but that doesn't mean we shouldn't do them. And the most important thing about this whole combination, the reason we're doing this is because we love what we do. We feel as a center that we are rooted in building healthier communities, healthy families, healthy children, and doing that in a way that is grounded in solid research that can be generalized or applied in other spaces. And this is a picture from a couple of years ago of our team that I still love to drop into presentations. And with that, we will wrap up and allow time for questions.
Thank you so much, Dr. Chisolm and Dr. Barnett. We have a question in the chat here from Andrew. He says, excellent talk. We've seen several similar problems in the Cleveland neighborhood, such as Huff. I was wondering if you've collected any go-along interviews where you get insights from residents as they move through their neighborhood.
So we haven't gotten to the point where we've done longitudinal interviews, where we've interviewed one person over a period of years. I think that's definitely work that's worth doing. And the challenge, of course, is that a lot of this work is built into grants that have limited horizons. And so you have to get another grant that allows you to expand your horizon in the work to do that. So what we've been doing instead is going backwards and interviewing people and talking about what their experiences were in the 70s and taking it forward, as opposed to interviewing somebody now and taking it into the next decades, but definitely worth doing.
I'd also say that in the interviews that we're doing, the way they're structured, we ask them to tell us the experience around their first pregnancy and then any subsequent pregnancy. Well, we do their first pregnancy and then their most recent pregnancy. So if they've had multiple pregnancies, that's a little bit of a way to kind of hear what their story might have been over time. And in the interviews, we also asked them about their childhood experiences. So how stable was their their homes when they were a child, what that neighborhood was like, if they felt safe both inside the home and within the neighborhood. So we try to get as much of their history, which is why the interviews are so long, um, to kind of to do that. Because like as Dr. Chisholm mentioned, it can be really challenging to from a funding perspective to do those longitudinal studies.
Darcy, I thought you had your hand up.
Thank you both for this amazing talk and the work that you're doing in Columbus, and definitely a model. I love the ending around integrating health and history. And I think a critique of a lot of population health is that ahistorical approach. So that's a huge contribution that you all are making. One of the questions I have, so acknowledging history, 100 years, I mean, that's a long time. So how do you think about accelerating change? What do we want change? When did we want it yesterday? How do you accelerate change? And what are the potential unintended consequences of not being patient when it comes to change? And I think about some of the work we've been doing with our Nutrition Equity Fund and this idea of patient dollars. So, I mean, the tensions between going fast and going slow.
So I think for me, one of the conversations I've been having with folks is I think we have to really work on changing our expectations. And what I mean by that is like, yes, we told this story of 100 years that it took this community to become what it is now. It shouldn't take us 100 years to get out of it, and we have to act with some level of urgency, but it is going to take us some time. We're not going to see a change tomorrow. Um, as Dr. Chisholm mentioned in some of the work that we've done on neighborhood, where the findings aren't statistically significant, but it's trending in that direction, like a positive direction, right? Because the outcome that we want to see from a significant statistical model takes time to build the numbers, right? So I think we have to change our expectations. And that can be really challenging, especially when we talk about something like infant mortality. We're talking about the death of babies, and families don't want to wait and they shouldn't have to wait, right? But I think that when we, again, there's a difference between like individual health and then population health. And if we're talking about changing numbers at a population, we have to be realistic about the time it's going to take to see that difference.
I think one of the things that we always want to try to do is to figure out what are the measurable interim changes. People need to see something happening. And so to the extent that you can find small wins and short-term wins and build on those wins, then it doesn't feel like you're just waiting for 20 years to create a change or waiting for 50 years to create a change. So part of it is breaking that change down into bite-sized pieces so that people are able to celebrate wins along the way, and be able to weather declines along the way, which may happen too. And I think one of the things we know for sure, and maybe that we've learned more in the past 12 months, is that things can change really, really fast. That's not always a good thing. And we know that there are ways to make things change really fast, but those may not be the best ways to get lasting change. We want to be really thoughtful about how we approach change in a way that is not just change for change's sake, that does not do as much damage as good, and that is measurable over time.
I don't see any other questions in the chat or the Q&A right now. Oh, here comes one. Jay says, wonderful talk. You mentioned that qualitative coding was a massive undertaking. I'm curious about the granularity of what you were coding. Were you mostly identifying broad topics, or were you looking for subtle linguistic patterns and emotions?
Yeah, so I like to use like an inductive coding mechanism. So like right now, I think our code book is probably it's over like 20 pages right now. And we are, so we're not looking for broad themes. So for the purposes of this presentation, I kind of pulled out some like broader topics that folks are talking about. But in the like forthcoming analyses that come out and manuscripts and presentations on this work, it is going to be more granular in terms of what the women are experiencing and the stories that they have to share. I think that's what makes it such a massive undertaking, that we are trying to uh, get down to like the essence of what they're saying and what they're experiencing. And so that just makes it more expansive. Because yeah, we could do a broader view of the analysis and do it much quicker, but we want to be able to really capture the experiences that they have.
Oh, Jay says thank you. Any other questions? And you can raise your hand too if you want to come off mute. We can turn your mic on. Oh, Shannon. Okay. I'm going to unmute you here, Shannon, so you can, okay. You should be able to talk now.
Shannon, we don't hear you.
Gotcha. Thank you for this great talk. So, health disparities and particularly maternal and child health and infant mortality is so multifactorial. And I was just, I know that it's preliminary and you haven't gotten to the next steps yet, but what are some of the intended, or possible plans for addressing some of these issues? Are you planning to address maternal health during pregnancy or prenatal care, or is it kind of an all hands on deck approach? What are some of the plans?
So definitely an all hands on deck approach. This part of the work, and I say this part of the work because this is really a citywide initiative around infant mortality. Our study is just a element of a larger body of work. Our work is really trying to figure out that space of how do we get um, new mothers, impending mothers, young families into safe spaces to live that allow them enough money to eat and do all the other things they need to do after they pay their rent in a way that then allows them the bandwidth to interact with all the other systems and services that will help their pregnancy be successful. So how do we work with investors to build affordable housing? How do we work with landlords to improve the quality of their homes? How do we build multifamily living that has integrated services in it for education and substance use and prenatal care? So really, we're focusing this particular book of work on how do we create the stability, sort of that lowest level of Maslow that allows people to maximize the success of their pregnancies. Now, there are other folks and even us in other parts of our work that are doing things around improving the quality of prenatal care, around building the way that populations are interacting with their providers so that they actually go to prenatal care and don't feel attacked when they're there. Looking at work around childcare, looking at work around home visiting in ways that, at an individual level, improve the health of the mom and the mother's readiness to be a mother and the father's readiness to be a father. Looking at our employment system so that people can get jobs that have benefits that allow them to reduce their stress and improve their financial situation. It is super multifactorial. And we got a whole nother building across the street that's working on all the biological stuff associated with it. We hope it all comes together to keep babies alive, but we know it is a heavy lift.
Thank you.
Well, again, thank you so much, Dr. Chisolm and Dr. Barnett. This is a great presentation. We'll make sure to share the slides, and this is also being recorded, so we'll put it on our YouTube channel in case people want to go back to it, or if you weren't able to join, you can watch later. So thank you all so much, and we'll make sure to get your contact information and links to everything to everybody.
Thank you.
Thank you.
All right, have a good day. Bye-bye.